Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Dr. Ahmed Fool. I am the head of geriatrics unit in Rashid Hospital in Dubai. Today I'm going to speak about Parkinson's disease and Parkinsonism. There is a big difference between Parkinson's disease and Parkinsonism, but let's speak about the clinical manifestations of Parkinson's disease. Parkinson's disease is a clinical diagnosis. It's not a disease that I need to do a lab test or an X-ray or a CT scan to diagnose it. It's diagnosed on clinical basis. What are the symptoms of Parkinson's disease? The most important symptom that will jump to our mind when we hear Parkinsonism is tremor. And I want to say from the beginning that tremor is present in 70% of patients when it develops in young age group around the age of 40, and it develops very rarely in patients at the age of 70. So the tremor is not, as was understood before, a pathognomonic sign. If you don't find it, it's not Parkinson's disease. This is wrong. Tremor could be present and could not be present. How the tremor of Parkinson's disease looks like. The tremor of Parkinson's disease is like I'm showing you now. It's like that. So the hand go in supination pronation, and the arm go in supination pronation, and the thumb move in sideways direction, and the fingers move this way. So the patient will be shaking this way. One of the characteristics of Parkinson's disease tremor is that it happens only during rest. When the person moves his hand or his arm to catch something, the tremor will disappear. Okay, once he fixes the arm, it will appear again. The implications of this is when I am drinking water in a cup, while I am in rest, tremor appear. When I catch a glass of water, it will disappear. When I am approaching the mouth and fix it, it will come back again, and I will throw all the water on myself. The tremor usually come on one side of the body. It does not come on both sides at the same time, because if it come on both sides at the same time, most probably it's not Parkinson's disease. This is regarding the tremor. The second symptom or the second sign is the bradykinesia. Bradykinesia is the slowness of movement. The person starts to walk slowly, move slowly, turn in bed slowly, to the extent that one time he become unable to come out of a chair. And in order to test this slowness of movement, I just ask the patient to do this movement. This movement, he will do it slowly, not like I'm doing it fast. So doing this slowly like that indicates that he has become slow. I ask him to unbutton and button his shirt. He will take a lot of time trying to open the button, and if he opens the button, I will take longer time putting it in the button again. This is one of the tests that we ask the patient to objectively prove that he is slowing. And for the general population, if I ask a person to come out of a chair and he's Parkinsonian like me, we will find that he will try to come to the front till he come to the edge of the chair, and he try to stand up many times till he be able to stand up. And probably he will need help to stand up. And his gait become slow and shuffling. Shuffling means that the sole of the foot become parallel to the floor. So he will not be able to raise the front of the foot and walk like that. He will be walking parallel to the floor. And probably you will hear the friction of his shoes on the floor, and you probably will not. But the point is not the hearing of the friction. The point is that he is walking his foot parallel to the floor. This means that he can easily trip over a loose rug or a wire on the floor, and the incidence fracture increases in patients with Parkinson's. this is the bradykinesia. The third thing is the rigidity or increased muscle tone, or decrease the how easy I can manipulate or move the arm of a person without resistance. So if I am a doctor and I am moving the arm of a patient, or moving his hand, normally there should not be any resistance. But if I find resistance when I am moving his hand like this, and probably I can feel the tremor during this movement, this indicates that there is increase in the muscle tone, which we call rigidity. And the important point to note here for this information is for physicians is that the increase in muscle tone occur in the anterior group of muscles and in the posterior group of muscles, so that when I am doing this movement, I will find resistance, and when I am doing this movement, I will also find resistance. This is important, and I will tell you later. I will tell later why it's important. Now, when Parkinson's disease starts to appear, we have two time peaks. There is a peak at the age of 40 and a peak at the age of 70. So we have people around the age of 40 start to develop Parkinson's disease, and people at the age of 70 who start to develop Parkinson's disease. So people who started at the age of 40 or around the age of 40 will live 30 years till they reach the age of 70. At this age of 70, they reach it to the final stage of Parkinson's disease. But people who started to develop Parkinson's disease at the age of 70, they are still remaining. They will live 15 years more, or probably more, with Parkinson's disease. Why I'm telling this? Because at the end of Parkinson's disease, 30% of patients become demented. And by the way, also 30% of the patients with Parkinson's disease have dementia. Now, I spoke about Parkinson's disease. I need to give a hint about diseases or illnesses which are similar to Parkinson's disease but is not Parkinson's, or are not Parkinson's disease. And how can I differentiate? And why I need to differentiate these diseases from Parkinson's disease? Because the other group of illnesses which are similar to Parkinson's disease, they are similar clinically. The patient is going to move slowly. The patient is going to speak slowly. His sound will be low tone voice. But the difference is Parkinson's illnesses that are similar to Parkinson's disease deteriorates very fast. In 1 year or two, the patient will become totally bedridden, totally unable to move out of bed, and he become demented very early. Within 1 year, dementia started to appear. But in Parkinson's disease, dementia comes after 20 or 30 years. So some people, when they diagnosed, when the physicians see a patient who is slow, we most of the time we are not sure if he's a Parkinson's disease or he is a Parkinson's syndrome or which one of the Parkinson's syndromes that are similar to Parkinson's. We are not sure. So we give the patient treatment. Sometimes we are not sure. We give the patient treatment like Sinemet. Patients with Parkinson's disease improve dramatically. But patients with Parkinson's syndrome, which is similar to Parkinson or looks like Parkinson's disease, will improve but partially. And within 1, 2, 3, 4 weeks or 1, 2 months, the response to Sinemet starts to disappear and the patient starts to become confined to bed again and deteriorates very fast. Despite we are increasing the dose of Sinemet to treat the patient will not improve. But patients with Parkinson's disease can get benefit from the Sinemet for up to 15 years or more. Now, what is the difference between Parkinson's disease that happens at the age of 40 and Parkinson's disease that happens at the age of 70? Parkinson's that happens in the age of 40, the patient can live for 25 years, 30 years with Parkinson's, but patients who develop at 70 can live only for 15 years, so it deteriorates faster than that which appears at the younger age group. Tremor are more prevalent at the young age group, but it's not prevalent as it is in young age group with elderly, because we can find Parkinson's disease without tremor in the elderly. Both of the young and old respond dramatically and nicely to treatment, to Sinemet. But Sinemet is one of the medicine that contain levodopa, which is the substance, the chemical substance, which is deficient in the brain in Parkinsonian patients. One of the characteristics or one of the problems with Sinemet or L-dopa is that its function wanes by time, disappears by time. So I need to increase the dose by time to get the same effect. By time, one day will come when I need to give a patient a very big dose in order to move. At this stage, the patient starts to develop side effects. These side effects are in the form of involuntary movement. We call it dyskinesia. This dyskinesia is involuntary movements that can affect the head. Patient always sitting, doing like that, or his shoulder moves involuntary, or his leg or his waist muscles, to the extent that this movement can throw him to the floor and get fractured. What if we reduce the dose a little to avoid this dyskinesia from happening? The patient will not move. So in order to move, you have to have the dyskinesia. If you would like to get rid of dyskinesia, don't take this big dose, so you will not be able to move. So you have to accept the involuntary movement to move. This is one of the difficult situations actually we feel in Parkinsonian patients. In young, this happens in young people. In elderly, most of the time they don't develop dyskinesia, but they develop hallucination. When the dose of the L-dopa increases, they start to hallucinate. And hallucination means they see things that's not present, like I see snakes, I see foreigners standing there, I can see fire, and they become afraid. So at that stage we reduces the dose of Sinemet so the patient will not be able to move. That's why we like at the beginning of the disease to use what we call dopamine agonist, which are medicine similar to dopamine, but it's not dopamine. It acts like dopamine. To avoid using dopamine very early so that we can use it later and he can stay functioning for longer periods of time. Because Parkinson's disease is not a killing disease. You are not going to die tomorrow or next year. You will live 25 years, 30 years with this disease. At the end stage of the disease, when we reach to the dose of Sinemet that causes this trouble, these side effects, or when you have very bad tremors that's not controllable with the medicine, one of the new treatments, relatively new kind of therapy is deep brain stimulation, what we call DBS. They put electrodes, physicians put electrodes inside the brain to reach to the place where the dopamine is deficient. Dopamine, when it is there, it creates electricity in the brain to transmit the information from one nerve to the other till it reaches to the muscle to move. But instead of dopamine, they stimulate the nerve electrically, doing the same function like dopamine, but by electricity, by battery. And this technique helps people to improve tremor by 50% improvement, and improve in the function of patients who reach to the stage unable to function by 60%. It's a good treatment, but it's a surgery. And it's not fitting everybody. It fits only people in whom Sinemet still brings effect. Because in late stages of Parkinson's disease, sometimes whatever the dose of Sinemet you are giving, the patient will not respond because the cells on which the Sinemet acts disappeared, degenerates completely. So these patients will not be suitable for the operation. Only patients who respond to Sinemet, even with side effects, there is no problem with side effects. You respond, you are fit for the surgery. One more thing, the patient should be mentally normal, should not be demented to go for this operation. Thank you for listening. And if you need more information about the elderly illnesses, you can visit the website forgivemenot.org. Thank you so much.